Let's jump right into the core logic for pneumonia. To nail this diagnosis, you need two things: compatible clinical symptoms plus an actual infiltrate on imaging. A chest x ray is generally your first step. And here's a strict rule to remember: you've got to get that x ray before starting empiric antibiotics whenever it's feasible. Now, what if you have an immunocompromised patient? Their cytokine response can be so blunted that an alveolar infiltrate might not even show up on that initial chest x-ray. So if you strongly suspect community-acquired pneumonia, but that x-ray comes back completely normal, your next best step is a CT scan of the chest. It's going to reveal that hidden infection. We also absolutely have to categorize pneumonia by setting, because the setting dictates your empiric coverage. If it develops outside the hospital, it's community-acquired. But the magic number is 48 hours. Once a patient crosses that 48-hour window post-admission, it becomes hospital-acquired pneumonia, or ventilator-associated if they're intubated. Why does this timing matter? Because it forces a major shift in our coverage. We now have to target MRSA and resistant gram-negative organisms. When we're treating community-acquired pneumonia in an outpatient setting, the decision pivots strictly on patient comorbidities. If your patient is otherwise healthy, you'll go with a macrolide or doxycycline, just depending on local resistance patterns and patient factors. But if they have major comorbidities, recent antibiotic use, or they're in a high-risk age group, you need to escalate. That means using a respiratory fluoroquinolone or combining a beta-lactam with a macrolide. If the patient requires hospitalization, we're shifting entirely to intravenous therapies. For your non-ICU patients, you can choose an IV respiratory fluoroquinolone or go with an IV beta-lactam plus a macrolide. But if they're facing ICU-level severity, we escalate immediately to combination therapy. You're looking at a beta-lactam plus a macrolide or a beta-lactam plus a respiratory fluoroquinolone. So how do we definitively decide who stays out and who gets admitted? We use the CURB-65 score. Give 1 point for new onset confusion, 1 for blood urea nitrogen over 20, 1 for a respiratory rate of 30 or higher, 1 for a blood pressure where the systolic is under 90 or the diastolic is under 60, and 1 for age 65 or older. A score of 0 or 1 means you can safely treat them as an outpatient. Anything higher dictates an urgent inpatient or ICU admission. Let's contrast typical and atypical presentations. Typical community-acquired pneumonia, usually driven by Streptococcus pneumonia, hits fast. We're talking acute fever, productive cough, pleuritic chest pain, focal crackles, and classic lobar infiltrates. Atypical pneumonia, on the other hand, is usually caused by mycoplasma or chlamydia. This is a much more gradual onset. Patients have a cough, maybe a sore throat, and bilateral findings on imaging, but they're often well enough to just continue normal activities. Keep viral pneumonia in mind too, which usually shows up with preceding upper respiratory symptoms and diffuse interstitial findings. For the boards, Legionella is incredibly high yield because of its extrapulmonary clues. It presents as a severe atypical pneumonia. Suspect it if your patient has a high fever with relative bradycardia or a recent exposure to a water source or an outbreak. The major giveaways are the extrapulmonary signs: prominent gastrointestinal symptoms like diarrhea, acute confusion, hyponatremia, and elevated transaminases. If you see that pattern, your next best step is targeted treatment with either a macrolide or a respiratory fluoroquinolone. Switching gears to pediatric patients, the key is to match the imaging pattern directly to your antibiotic choice. If a kid has an abrupt onset of fever, chest pain, increased work of breathing, focal crackles, and a lobar pattern, that strongly suggests pneumococcus. Outpatient therapy here is amoxicillin. If they're admitted, you step that up to IV ampicillin or ceftriaxone. But if you see a more gradual onset with a bilateral interstitial pattern in a school-aged child, think atypical organisms and treat with a macrolide. You have to be really careful to differentiate the two aspiration syndromes. Aspiration pneumonitis is a sterile chemical lung injury from inhaling acidic gastric contents. It causes abrupt hypoxemia and dependent infiltrates, but the trick is it usually improves within 24 to 48 hours with just supportive care alone. Aspiration pneumonia, however, is a true bacterial infection driven by anaerobes. This happens especially in patients with dysphagia, seizures, or intoxication. You only initiate active antibiotic therapy if they develop a persistent fever, rising leukocytosis, purulent sputum, or if their infiltrates keep worsening. For those patients at high risk, maybe they have altered consciousness or documented dysphagia, secondary prevention is the next best step. Establish swallow protection mechanisms by elevating the head of the bed, maintaining rigorous oral care, and implementing diet modifications like thickened liquids. Swallow's strategies, like a simple chin tuck maneuver, are also vital for protecting that airway. If you get a chest x-ray showing a cavitary lesion with a distinct air fluid level, you've just confirmed a necrotizing lung abscess. This is classic for patients with strong aspiration risk factors. Think substance abuse or poor dentition, who present with fever, night sweats, white loss, and foul-smelling sputum. Since this is primarily driven by oral anaerobes, your empiric treatment requires targeted anaerobic coverage. Intravenous ampicillin sulbactam or clindamycin are your go-to options here. Pay close attention to the location of recurrent infections. Recurrent pneumonia that maps to the exact same lung lobe is a major red flag for a localized bronchial obstruction. That obstruction could be extrinsic, like adenopathy or a neoplasm, or intrinsic, like a foreign body. If you have a patient over 50 with a significant smoking history and same lobe recurrences, your immediate next best step is a CT scan of the chest to rule out an underlying malignancy. Moving into the pleural space, let's talk effusions. When pneumonia is complicated by a small pleural effusion and the patient has no respiratory distress, you can just continue antibiotics and monitor them closely. But if you start seeing clinical signs of hypoxia, respiratory distress, or if the effusion is moderate to large, that dictates an immediate shift in your pathway. You need to move straight to an ultrasound-guided evaluation, start IV antibiotics, and evaluate for drainage. Biochemically, we have to look at the fluid analysis. An uncomplicated effusion is just a sterile inflammatory exudate. The pH will be above 7.20 and the glucose will be normal. But when actual bacterial invasion occurs, which creates a complicated effusion, those bacteria start metabolizing. They consume the glucose and they produce acid. So a complicated effusion is defined by a pleural fluid pH falling below 7.20, glucose dropping under 60, and an exceptionally high LDH. The crucial final point is about definitive management. Once that bacterial invasion results in an acidotic, complicated effusion, or you're dealing with a frank empyema with purulent fluid and a positive gram stain, intravenous antibiotics alone are going to fail. Physical evacuation of that fluid via chest tube drainage is absolutely required alongside your antibiotic regimen.